So I think we can get going with tonight's discussion. Before we begin, I'd like to extend a sincere thank you to the Breast Health Foundation for organizing and hosting this important discussion. It's another fantastic event to add to their long list of successful webinars. Initiatives like these play a vital role in supporting the cancer community by providing education, guidance, and a safe space for meaningful conversation. These discussions are not only beneficial but crucial in helping our patients, the families, and caregivers that navigate these challenges that accompany a cancer diagnosis and a treatment journey. So, tonight's discussion is called Hoping for the Best, Planning for the Rest. And I've been assured that it's not an end of life discussion. It is a conversation about planning ahead, reducing uncertainty, and creating peace of mind. Helping families navigate the important decisions is where the focus lies. So, as I said, we're going to encourage questions throughout the evening. We will incorporate audience participation, and I'm going to kick it off with a very quick little interactive poll. If you see it popping up, please answer. Give us your thoughts of what you did, and we'll take a look at that later on. What I'm going to do now is I'm also going to invite all our speakers to turn their mics on, turn their cameras on, and we'll get ready to start tonight's discussion. I am going to offer our first question off to everyone who is here. I'm going to give everyone a moment to introduce themselves. We're going to go down our list. I believe we have Professor Benn, who won't be able to join us on camera, but she is here. She doesn't need much of an introduction, but Prof. Benn, you're the head of the BCCE. Why don't you kick us off with your own introduction there?
Hi, everybody. So thank you for this really, really important topic. I just want to say when I saw the topic, I thought, oh, you want me to put that on my status? Well, you know, I look after so many people, and I'm that person who switches off the radio when it's like, have you got your insurance sorted, etc. And I do remember at the start of SARS-CoV-2 where I changed my wills and put my middle child in charge of everything, and my other two kids said that's not fair. I said someone responsible, and they said that's not fair, has to make sure that the systems and you guys are fine. So I get that these are not the discussions that we have to do, and it's so important, and we absolutely, all we wish for on my side is that we can look after people properly and offer them long years of safe, health, and happy living. But all of us know that at some stage our streepie is for track in the sand. I probably said that wrong. Okay.
Thank you very much,
Right.
Prof. Benn.
Okay.
I'm going to move on to our other two doctors. Let's start with Dr. Fenter. Perhaps you can introduce yourself, your involvement in a topic such as tonight's, and give everyone just a moment's thought on what we're going to discuss about.
Thank you. I'm in the Western Cape and the wind is blowing in the background. So if something crashes, it's because of the wind. I'm an oncologist, but I now work exclusively in palliative care. And if we talk about streepies in the sand, I'm reminded of a little cartoon with Snoopy and Charlie Brown, and they're sitting on a pier, and Charlie Brown says to Snoopy, we're all going to die one day. And Charlie Brown says, but every other day we're not. And I think palliative care is for me about those other days. It's not about that one moment. And so I think for me, this planning ahead and thinking about what matters and how do we want to take control of our days, how do we want to live them, whether on treatment or no longer on treatment, is what it's about. So giving some autonomy back to people and the best days possible, and hopefully many, many ones. So yeah, for me, that's a passion, and I'm very excited to be part of this conversation.
Thank you so much. Dr. Mathe, please, if you'd be so kind as to introduce yourself and your interest in tonight's topic.
Good evening, everyone. Yes, my name is Penelope Mathe. social worker at Greendale House. I've been in this field for the past 16 years. I started as a pediatric palliative social worker at Soweto Hospice. But yeah, now at Greendale House, it's still the same, you know, with rebranding. So they changed the name to Greendale House. So my interest in this topic today is, you know, palliative care, it's a journey. So, you know, planning ahead is part of the journey. And we plan and we hope for the best. So I'm very excited to be part of the panel today. And thank you for inviting me.
Thank you so much for joining us. And last but not least, our two experts from the legal field who we'll be speaking with more a bit later in the evening. But start us off. Introduce yourself. John and Evie, I believe you're sharing a camera tonight, so why don't you two go together?
Thanks very much, and good evening to you all. Dominic, it's a pleasure to be part of this amazing opportunity. BHF, as always, we're so privileged to work alongside you guys and the work that you do. And to Carol, obviously, thank you so much. John Comninos, I'm an attorney in private practice. I've been practicing for almost 30 years, and we've pretty much seen it all. And there's one adage that I always say to my clients when I'm giving advice or dealing with situations that are complicated: the more information we have, the better the decisions we can make, and the better the decisions we make, the better the results. And I'm hoping tonight that we're able to impart some of that knowledge to our viewers and listeners in the hope that they will take it in their stride and make the right choices for the benefit of not only themselves, but for obviously the loved ones that they leave behind.
Thank you so much. Evie, please go ahead. No stress.
Thank you. Good evening, everybody, and thank you once again for this opportunity. I'm Evie Michalopoulos. I'm a senior paralegal and the COO of Comninos Incorporated. Been in the profession for just over 22 years in the legal profession. I also am the co-founder of Superlawyers, online legal advisors, and also the founder of the Michalopoulos Cancer Project, a project that's very special to my heart and in memory of my late mom. And I'm very honored to be here with you today to share this platform and to share some inspirational ideas and planning.
Thank you so much. And we have a wonderfully diverse panel tonight about these discussions. So I'm going to just go and dive right into it with everyone. When I heard the title, Hoping for the Best and Planning for the Rest, and I'm sure other people can follow my line of thought as well, I assumed tonight might be a difficult conversation. And it's a topic that is not often brought up. I'm going to put this question out to anyone who wishes to address it. Why do you think that intelligent, caring people so often avoid these type of conversations until a crisis forces us to address them?
So Dominic, I just want to start. Can you hear me? Yeah.
I can hear you loud and clear, Prof.
So I think we're almost too scared to consider the fact that something might happen. So I'm going to start this off with, I was sitting on a plane on a very nice seat, coming back from an oncology congress, and we were waiting for the last person to get on the plane, and the seat next to me was empty. And I saw this person come on, could barely walk, and I saw a little bit yellow and jaundice. And I kept on going, please don't sit next to me, please don't. You know, when you sit there. And the person did, right? And I was working on a presentation, and she looked over and she said, oh, you're writing about breast cancer. I have end-stage breast cancer. I'm dying. And I thought, oh, you know, I have never been more inspired by anyone in my entire life. She says to me, I'm going to lecture at the same congress, and I'm going to say to them, like I said to my husband, are you sure you want me to die at home? And because the family said yes. She said, right, and I'm not going to be here, but you are going to lie in that bed the next night, and you are going to maybe want to have someone else there, and with all the memories of me. And she had such a frank conversation with me on the plane that it revolutionized my outlook on what we fear and why we don't address it. So I think it's because we fear it, all of us.
You definitely bring up a good point there, Prof. Benn, about fear. I'm not sure if anyone else wants to make a comment on this before we delve into a couple more specific questions.
Dom, if you don't mind, just a quick one. I think not only are people afraid, but people are not educated. And I mean it with the utmost of respect. And I think people often feel like they need to be highly intellectual or to be close to people that are educated themselves. And they don't realize that it's quite a simple process to follow. So we're aiming to try and obviously, and I'm hoping through this platform to be able to teach people about what they really need to know, because it is quite basic as long as they understand that it's in the best interest of everybody concerned.
That's a brilliant point you do bring up there, John. Thank you so much. And platforms such as these providing the education where needed helps us better address these topics. So I'm going to direct a question directly to Dr. Venter and Dr. Mathe. Let's talk about palliative care and the term palliative care. I'd like to ask you, what are some of the biggest misconceptions that people have about the term palliative care, and why there might be that niggly thought at the back of people's brain that the assumption is palliative care means that I'm giving up? Let's address that thought.
Okay, can I start, Dr. Venter?
Off you go.
Okay, palliative care, if we can just explain it to people, we say it's a holistic approach to care that aims to improve the quality of life of individuals living with serious chronic or life-limiting illnesses, and it involves supporting the family. It focuses on the prevention and relief of suffering through the early identification, assessment, and management of physical symptoms such as pain, as well as psychosocial, emotional, spiritual concerns. We say it is a holistic approach. Palliative care can be provided alongside curative or life-prolonging treatment and is appropriate at any stage of a serious illness. So if I can just go to a misconception and then allow Dr. Venter to say something as well. One of the biggest misconceptions out there is that palliative care is only for people who are dying. In reality, palliative care should be introduced early in the illness trajectory and can be provided for months or even years while a person continues to receive active treatment. So palliative care is not for dying. So early integration, we always say early integration of palliative care has shown to improve symptom management. Dr. Venter will agree with me, quality of life, and support to the families, because we are not looking at the patient alone, but we also focus on the patient's carers and the family. Thank you.
Thanks, Penelope. That's great. I think what I would want to add is that this is usually offered by a team of people. So most typically a nurse, a social worker, and a medical doctor who works alongside the oncology team. And I think some of the misconception is historical. Previously, people would receive curative treatment, oncology treatment, and then be transitioned to a hospice. Whereas now there's clear recognition through research in the last decade or so that offering this, what we call extra layer of support to a patient and their family, really supports the whole person. It allows the oncology team to look at the cancer and the treatments, and that's consuming and time consuming in a consultation. There's a lot to talk about. And then you have a palliative care team where you can do some of the other talking. We can spend a whole hour on your pain and how we need to address it, whether through medication or other aspects. So really a care team who walks alongside you. I had one patient, the wife, who said to me, the oncologist kept asking her, has she met now Dr. Venter? And she kept on thinking, why do I need Dr. Venter? I have an oncologist, I have this, I have that. And then she realized she felt like she had we weren't involved all the time, but there was this net where if they fell, they would fall into this net of support. So I think, yeah, for me, that's what palliative care is all about, and trying to get the most out of every day. And then this whole concept of thinking ahead a little bit about the what ifs, which are hard, and a palliative care team is well suited to help start that conversation. These are the things that you need to start thinking about. Have you thought about this? Because, I mean, one can avoid it, but it's in the room. It's the elephant in the room. And so a palliative care team can really help crack that open a little bit. And once you do that, there's great relief usually.
Thank you so much. Some very interesting
answer.
points there and relevant ones. I don't know if, John, Evie, I'm going to give you the opportunity at any point during these discussions you want to join in and make a comment. Please feel free to do so. I'll let you do so. I'm aware the first couple questions are very medically focused, and we'll get to your questions, which I do have a number for a bit later on. I'm going to move on this thought with palliative care and dive a little bit deeper and use the term planning ahead. And I want to ask our doctors, Prof. Benn, Dr. Mathe, and Dr. Venter, many people do still associate planning ahead with giving up hope. And I'd like to know how you, with your specific care in oncology, how patients understand that planning and hope can exist side by side very easily. And if you do have an example of a patient who was able to plan ahead carefully and remain hopeful, I love these analogies that you do give forward. I don't know if any of you would like to start there.
Okay. For me, one of the most important messages that we share with patients and families is that planning ahead is not about giving up hope. It is about preparing for different possibilities while continuing to live meaningfully, like in the present. Hope and planning are not opposite, they coexist. So a person can hope for a recovery, person can hope for more time, a person can hope for successful treatment, a person can hope for a meaningful experience with the family and their loved ones, while also ensuring that their wishes are known should the circumstances change. That is very much important. So we in palliative care, we talk a lot about advanced care planning, which empowers individuals to maintain control over their care and decision making. You know, that often reduces anxiety because important decisions are already being made and considered and also communicated to everyone around the patient. You know, in this way, planning actually strengthens hope by allowing people to focus on what matters most to them. That is me.
So I can't stress the importance of thinking as the palliative team, and I hate the word palliative. It is the team that is actually the supportive care team along your whole journey. So often as people practicing in the oncology field, we are faced with people who say, I don't want any treatment and I don't want any more treatment. Or you've got somebody who you know that they're not going to manage the treatment. And it's important that when you talk through it, and if you're not comfortable with it, and there are people who are happy to say, I don't want to do anything and I don't want to do anything more, that you get experts into your team who can guide the doctor, guide the patients, and guide the family, because each one of us have our own journey, and so do they. And it's about respecting but helping. And I find that is so important with every single patient.
Thank you so much, Prof. I don't know if Dr. Venter, you have anything to add on that point?
Yeah, so for me, that's one of the most important questions, is the one around trade-offs. Because I think treatment, there's always some kind of trade-off with oncology treatment. It's often quite toxic, more often than not. It impacts on quality of life, you know, in terms of symptoms, time in a clinic, blood tests, living from one scan to the next. It does become, you know, such a big focus of one's life. and one has to be quite clear what you are hoping for with the treatment, and does what you're hoping for and what is offered, do those two align? Do they, is what you're hoping for reasonable and realistic? And if it's not, is there another way of approaching things other than treatment? And I'm not talking about alternatives. I'm talking about, as you say, Carol, not then choosing not to have further oncological treatment, but focusing more on pain control, spending time with family. Often people say this, it's like a normal, ordinary day is what I crave. And not to have to be thinking about the next scan, and just changing my focus a little bit, and to then kind of figure out what are we hoping for. So, hope is such a nebulous thing. I think one can have a conversation and figure out, so what am I hoping for? I'm hoping to see the birth of my grandchild. I'm hoping that, that I can be pain-free. People hope for different things. So having a conversation and figuring out what are the different things that we can hope for. It's not just one thing. And and how can we make that possible? That's a nice task always for us in our conversations with patients.
Thank you so much for that. So I'm going to throw one more question out there, and I'm going to apologize before I put it in here, because this is definitely a bit of a bait, a loaded question, but it's going to lead into a further discussion and some questions from our audience. I'm going to say, in your experience, doctors, and even to our legal team as well, what difference does it make that you can identify when patients and families have had these conversations early? And have you ever had a situation where a family has said, I wish we'd spoken about this sooner. I wish we'd addressed this elephant in the room before this point? I welcome anyone to start that conversation there.
Say that last line again, Dom. I missed it.
Question is, have you ever heard a family say, I wish we'd spoken about this sooner, emphasizing on whether it makes a difference if patients and their families had had these conversations early?
Can I tell you something? I hear that more often than I should. So it means that from a clinician point of view, I'm acutely aware of our failings in incorporating aspects into our care. And I often say it's probably because of the word palliative. So I always try and sell it differently. It's around helping people make sensible decisions around what is important for them and not important for them in oncology care. And like you say, going through chemo is horrible, and if you're going to go through it and have a poor outcome, what do you tell the patient? If you come lost in the race, you've got a link in the brain, what do you tell people? And who's helping you with it? So I think that I've never heard anyone say, I'm not sorry that you've discussed this.
Yeah. That's so true. Most people in my experience, it's a hard conversation, and sometimes they're tears and it's awkward, and then at the end of it, thank you that we were able to speak about this. That's and then I think, just to bring the rest of the participants on board, there are a few things that when we say talking about advanced care planning, there's about healthcare planning. What do you want? Would you be, if in case you became sicker, what are those things you need to think of? And then there's the admin, the legal, the wills, and all of that, those things that also need to happen in the background, John, that you guys are involved with. And I find often people, those are the things that tomorrow feels like a better day because today I'm not up for it. And then I often see that tomorrow never comes. And that's sometimes really disastrous. Both the medical planning, but also the life admin planning.
Yeah, and I can speak from personal experience, and I wish that this question is so relevant to what my experience was with my late mom. I wish we had done this earlier. I wish we had those conversations with my late mom, who passed very suddenly and didn't have a will, didn't have anything left for us to understand what she would have actually wanted, had she had been told that she was in that position. And I think, honestly, the biggest challenge I faced at that point in time was not just trying to understand what was happening around me because it happened so quickly, but it was also because I didn't know how to approach the subject with her. And as a family, we had that same difficulty. We weren't able to decide who was going to have that conversation. Initially, I, with the help of at that point in time was Hospice Wits, which is now Greendale Hospice, helped us through that process, but we never had any of those documents in place. So it is really so important to have it, just to understand what my late mom would have personally maybe wanted something done or given away or said or phoned or spoken to someone, which we didn't have at the time. So it is really so important to have.
Thank you so much for bringing up those points. And here comes the curveball that I wanted to lead into this. It's a question that we received in our chat. And the question comes up is, what are the options to support a person who doesn't have any immediate family? No living siblings, parents, nor a spouse. How do you advocate for them in that situation where they don't have that natural support structure?
Penelope, that's your question.
In those situations whereby the person has no carers or no one at all, so usually if the patient can still communicate, we engage the patient in his or her care planning and decision making. And if there is a need, then if a person has legal advisors, then they are brought in. And also the interdisciplinary team as well plays an important part in that situation, because like Dr. Fenter said, we work as a team. So just because a person does not have anyone to support them, it doesn't mean they must not be involved in any planning or, advanced care planning. They need to be supported by the team.
Thank you so much for addressing that and bringing that up. If there are no more comments on that specific question, I'm not sure if you want to chip in there, Dr. Fenter. I am going to move on to a little bit more of an in-depth look here. And this I'm going to focus towards both Dr. Fenter and maybe even Prof. Benn. The question is, when does cancer treatment and quality of life planning begin to overlap? And how do you decide when it's appropriate to introduce palliative care alongside active treatment?
So my answer to that is it's easy. As soon as the oncology treatment is affecting life and family in the patient's perception of a negative, okay, whether it's clinical diseases becoming metastatic or really battling pain side effects even around treatment and drugs, then you need to get help in from a team to almost to step back and make sure that you are not pushing the wrong thing in a clinical direction. Or it's so important. The value of team, multidisciplinary team, is critical. So when a patient is not managing and life and home and everything is being affected, then you need help. And family needs help, the patient needs help, and the doctor needs help too.
So I want to challenge that.
Hey, good. I love that.
And say that that's too late then.
Okay, I love that. Okay, I accept that 100%. I would have it right from the word go.
Yeah.
Except that I can't get, when I mention it from the word go, people go, hold on. So as soon as I see a mini hiccup, and it can be a minor nausea, this, that, etc., then for me, you say we're bringing in the experts to help. Okay, so I fully agree with you. It should be at the time of diagnosis.
Yeah, and so
But
that's
that's
what all the national cancer guideline, international cancer guidelines suggest. And I think initially it can be a meet and greet. It can be, this is who we are, this is why we're here. And our, our support is light, and it's just in the background. But then what's a good word of, when the pawpaw hits the fan, we can anticipate some of that already and perhaps avoid some of that, make sure that pain doesn't become extreme before someone intervenes. So I think, we have a long way to go in challenging all these misconceptions. There are things that are moving, like, for example, medical schemes are now acknowledging this, and they are paying for this extra layer of support outside of a patient's oncology benefit. The Department of Health is slowly coming to the party. We're busy developing or reviewing our current policy. And all of this highlights that palliative care really should be walking alongside treatment. And it is about, I suppose, how you sell it. But for me, to take the emotion out of it would have been a lot easier to say everybody who has a cancer diagnosis that is serious requires this extra. Like you see the oncologist, at the same time you meet the palliative care team. That would be my ideal, I think. And some might need a little support and others might need a lot, but that depends on the journey.
So before I move on to a little bit more of a technical discussion, I'm going to throw one more question into there, and it's a difficult one to answer. South African healthcare realities is a thing, and sometimes that means the medically ideal option and the financially realistic option are not always the same. How do families navigate these difficult decisions where it's an advocacy for we need more care, we need more help, but maybe there's a little bit of struggle in accessing it or affording it?
In affording oncology care, or
Well, I'm saying particularly some medical aids will look at oncology benefit as one bundled package. And when it goes forward to saying you need more, you need a carer, you need additional assistance, is that always included in the medical aids, or is it something that we need to be aware there needs to be perhaps a more public offering for it?
So most of the bigger medical schemes, I think probably about 80% of people who have medical aid cover will have access to a reasonably comprehensive palliative care benefit, which implies you'll have access to the medications you need to manage your symptoms. You'll have access to the consultations of the entire team, social worker, doctor, nurse. You'll have access to some equipment if you might need it. The one thing that they won't pay for on a long-term ongoing basis is an additional carer in the home, who's a trained carer who can do basic care like helping with washing and that kind of support that they won't pay for on an ongoing basis, but they do usually pay for about 2 weeks or so for that kind of additional care in the home. There are some schemes. I'm very involved in that domain of engaging with medical schemes. There are still some schemes, I'm happy to name and shame, who don't have a palliative care benefit despite engagement for many years. But it really is, some would say it's a human right. It's part of the universal healthcare coverage. It should be available to all South Africans, not only those who have medical schemes. It really should be available to all South Africans.
Thank you so much for addressing that, Dr. Venter, and I'm not going to put you in a position where you need to name and shame anything. It is lovely to hear that there are options out there, and that for most medical aids, it is almost a prescribed minimum benefit where those access is doing. I am unfortunately going to say to Prof, just one moment. I am going to say to our audience that unfortunately we're not going to allow any of our audience members to unmute themselves and join the discussion. Feel free to use the chat and I'll do my best to include them there. Prof Benn, if you want to make your comment now.
Yeah, so there are two things when someone's just diagnosed that I find that they just don't deal with when you mention it. The one thing is we when we talk genetics, which we always want to do, and the other is when we mention the word palliative care. I think there's a need to rebrand what you guys do. It is so critical to call it supportive care or something, because as soon as you say you've been diagnosed with the cancer, this is what we're doing, and we're going to get someone from palliative care involved in your supportive care, they automatically assume it's about end of life care, which it's not, right? So there needs to be a complete rebranding on it so that people understand. So I don't like to use the word. I try and use supportive care early on, because as soon as they see that the person you're sending them has got palliative care, they automatically think that's it.
Thank you. Agreed, Prof. And I'm gonna throw the comment in that came from our chat that our discussion tonight, even though we are focusing on oncology care and cancer care, it's not only about cancer. It is about all life-threatening care. Our specialist tonight and from our foundation just has a specific focus on cancer. I'm going to throw one final question here towards our healthcare worker and Dr. Fenter before we move on to some chats with John and Evie. And that's a term that this is honestly the first time I've actually come across it myself. The question is about the role of an end-of-life doula. I hope I'm pronouncing that correctly. And when is the best time to introduce the idea of end-of-life doulas? And I see that there are some organizations that specifically deal with this end-of-life support alliance or sacred dying. Perhaps either of you will know a little bit more and can address this question.
So these are trained individuals who support families through this process. I think equally when they come on board is probably quite fluid, and I would imagine mostly also preferably sooner rather than later. So that's because it's very relational, and the support is and there might be a doula on the line who can tap for us in the chat, but it's supporting the family and the patient with some of the basic care needs, but also around the emotional and the spiritual aspects of a end of life journey. So they're not medical providers. They are, but they bring a very holistic, supportive, calm space to support the family and the patient.
Thank you so
and
much.
how they integrate with the team, they can be a member of the team. They're mostly available in some of the bigger centers. I think often, in my experience, finances are sometimes a bit of a hurdle to get over because they're not typically reimbursed by medical schemes. But sure, absolutely an important part of a team if they're available. Yeah.
Thank you so much for that. Thank you so much for clarifying that. So we're definitely agreeing. Planning ahead is not about expecting the worst. It's about reducing uncertainty and preserving choice. So let's have a discussion that's more around the practical decisions that people can make before a crisis occurs. And I'm going to bring both John and Evie into the questions here and ask them to put a little bit of a blanket discussion for us. Many people have heard the terms like living will, advanced directives, medical power of attorney, DNR, but we're not exactly sure about all these terms and where they fit into the decision-making process. I'd love to give the two of you a chance to just cover some of the terms that we're expected to see. While they do this, I'm also going to put a poll in the chat to see how many of our audience tonight has come across these terms or thought about them themselves. I'm going to hand it over to you two now.
Thanks, Dominic. A good question, and sometimes can be confusing. I think the most important thing that we'd like everybody to understand is that a living will and a will are two completely different things, although they're interrelated. So a will is a written document that is drafted by someone called a testator or a testatrix if it's the feminine. And basically what it is, it's a set of rules and guidelines telling their loved ones and people who are going to assist in the administration of the estate what they would like to do with their assets. It has certain requirements in terms of the Wills Act, and as long as those requirements are met, the will is deemed to be valid and then subsequently lodged with the Master of the High Court in order for the estate to be administrated. When we talk about a living will is usually, and it's not always part and parcel of a will, I might add. It's something that most people sometimes neglect to add, or alternatively are not given the correct advice. And a living will is basically a do not resuscitate type of document where in the event that a individual is dying, and they have no possibility of recovering from their illness or from their disease, they put a discretionary paragraph in their will to say that in the event that this happens, they would like a family member or a medical practitioner to confirm that they will no longer be able to survive this process or the medical procedure. And should they be incapable of understanding the consequences of their actions post an event, they will be asked not to resuscitate the patient. So it's quite a difficult scenario for a family member to accept, but one must always follow the wishes of the individual that's passing. Advanced directives in terms of cancer patients. I'm sure, Margie, I think that was one of your mandated questions. Perhaps you would like to take that on. I have some knowledge, but I don't believe I have as much knowledge about that as you do. Can I pass that question to you?
Sure. So I think for me, advanced directives and living wills, we typically use interchangeably. I think an important component of that is identifying someone that you trust that is able to make decisions on your behalf around your healthcare, should you not be able to do that for yourself. So you need to think very clearly about who you identify. It can be more than one person, but that person is then entrusted to make those decisions on your behalf. A living will, I mean, you can download a template off the internet, and typically it says, if whatever is happening to me is not reversible, I don't want to be put on machines, I want to be kept comfortable in whatever way is necessary, end of story. The problem for me with that is that it's often, and the healthcare practitioner needs to honor that, or they need to acknowledge it and honor it, even though it's not legally binding. The healthcare proxy is, if you've identified a healthcare proxy, that person's decision needs to be followed. And there's a lot of work happening at the moment in the background around clarifying this, because it is confusing for even people working in the field. The thing for me that's important is, if you really want autonomy and some control over what happens to you when you're not able to make these decisions, it's not just about completing a form and signing it. The people that you trust need to know how you think about your disease process and what your values are. How much are you prepared to go through the possibility of extra time? They need to understand that. Otherwise, you leave them in the lurch to make this decision, and they actually have no clue. The burden of decision making is on them. So to have this conversation with your healthcare or your surrogate decision maker is important. And I think important to include your healthcare practitioner in that process, and or the social worker, someone from your palliative care team, because this is a different kind of conversation when you're healthy and well, and this is something maybe down in the future, blah blah blah. It's very different to someone who is now diagnosed with an illness where things are a little more uncertain but more acute, and more important and more immediate. And even then it changes over time. So what you think now might not be true and relevant 6 months from now. So it is an iterative process. And I think ideally something that should be supported by your healthcare team, because it's also done within the context of understanding your illness and what the possibilities are, what the likely outcomes might be. So it's not as simple as just downloading a template and signing it, although that's a very good start.
I think if I could just add one more thing, I think that's very important, is that the patient who is making the advance directive, they should definitively have mental capacity at the time that they make those decisions. You know, they need to be able to understand the information and obviously appreciate the consequences, be able to weigh the options and communicate those decisions. So the best time to discuss an advance directive is usually enough when the patient is able to think clearly and obviously be in a position when his last wishes are medical reality for them, I believe.
You
And then
definitely bring up a good point there, John, and we'll definitely let you continue now in a moment, Dr. Fenter. I do remember getting a question wrong myself on a medical ethics exam that said if an emergency doctor is going to walk in on a patient who is still awake but actively in the process of overdosing and says, no, I refuse treatment, I don't want it, is the legal prerogative for them to treat them or follow their wishes of not? And the answer I got wrong was you have to be in sound state of mind to decline treatment, and if someone is in the process of harming themselves, they're not in sound state of mind. Maybe not exactly relevant for this situation, but it does bring that thought of making sure the documents are made in sound state of mind. If you want to continue that conversation, Dr. Fenter?
No, I'm off track now.
I can just jump in quickly. Just from my experience, as much as I love the internet and ChatGPT and all these wonderful, amazing things that are happening, we always advise against downloading just simple templates, particularly because each individual client or patient has bespoke needs and requirements. And often some of these templates are not fully appreciated in terms of South African legislation. I mean, we've had people that have downloaded templates from the United States and things like that, and some of those laws are not applicable here. So you can always use them as a guideline, but always take proper legal advice before signing any document that will have a real effect on your future status.
Thank you, John, and definitely a good point to bring up there just in case. Dr. Fenter, if you do want to continue, interrupt me at any point, but I am going to take your point a little bit further, John, and ask if someone does now have this living will or advance directive, how do they ensure that their wishes are respected and followed then during an emergency? Who should have a copy of this? How does it maintained and done validly? I'm not sure if Dr. Fenter, you want to comment there, or either of our legal representatives.
Just from my side quickly before Dr. Fenter answers, definitively put in writing, dated and signed. Obviously a confirmation that the person that's signing it is of sound mind and acting voluntarily. Easily to understand, clear English language or the language of your home language choice. I would suppose identifying the medical circumstances in which it would apply, notification or describing of your healthcare proxy or trusted representative. Again, discuss it with your treating oncologist or doctor, and then definitively give a copy to family members, doctors, whoever you think would be an important part and parcel of making those decisions for you. I would imagine, and the advice would always be from our side, is get your will in place, get your advance directive in place, get your living will in place, and keep everything together in a safe place, in a safe spot that people that you trust have access to it. That would be my advice in terms of how one would go about it. Yeah. Dr. Fenter?
Yeah, I want to say watch this space, because there is, I don't know, John, whether you guys are involved in it, or there is a group now at the moment with various stakeholders who are really engaging with this and will be writing proper guidelines and putting out statements to support the South African public and the healthcare professionals to clearly understand, you know, how this works, what is legally binding, what should be done. But my understanding from these last conversations have been that the most important thing is identifying your surrogate decision maker, and that you can write on the back of an envelope, date and sign it, and that is sufficient. The thing is just to have that person understand how you think about your health. And it's so, you know, when you start with a piece of paper to say, what are the medical situations what needs to be done in what medical situation, it's almost impossible. It's much more about, so just to say that it's important, and we often say in a clinical context, well, we can do this because the patient did have a living will, by which everyone assumes the implication is that people focus on quality of life more than on wanting treatment at all costs. That's kind of the assumption I think that people make. But to really have your wishes honored, it's easier to have someone who understands how you think. Are you someone who has small children, and no matter how small the chance of recovery is, you want to take every available option to you to try and reverse whatever's happening? Or are you, late 80s, you feel I've lived my life, I am not prepared to be in ICU on machines, no matter what the medical situation is. So it's more about those kind of concepts rather than this, that, not this, not that. It becomes so hard. There's an organization who has a very robust, long document that goes through everything, pig feeding tubes and machines and dialysis, but it's overwhelming to complete something like that on your own. And then often people say, I can't, I want to, and then I look at that form and I think, I can't. So get your general practitioner involved. Make an appointment and say, I want to come and speak to you about this within my own healthcare context. These are the things that I think are important. How would we put this on a piece of paper? And then give that piece of paper, copy to your proxy, a copy in your folder that goes with you to the emergency medicine room, a copy to your oncologist. I don't know. What do you think, Penelope?
No, I support you, in everything that you have said. I have nothing to add.
Thank you so much. And I'm going to twist the conversation a little bit to something that's associated here. We will try and come back to our legal discussions and some more information there when we can. There were some questions in the chat, but we do have to be cognizant of the time. The question I want to bring up here is when someone can no longer communicate their wishes, or if there's someone with special needs patients in terms of counseling. A particular example we received was someone with cerebral palsy who's mentally and physically challenged and has just been diagnosed with breast cancer. Those two questions fall in the same track. What challenges are faced and how can they be resolved if these conversations have either never been taken place or can't have taken place, and those decisions need to be made? What happens in that situation?
In those situations where a patient can no longer communicate, we rely on the family member, or if there is a proxy, a person will make decisions on that patient. We rely on them because now we cannot ask the patient, or even if we can ask, if the patient cannot respond as to say, this is what I want, this is how I want to be treated, then we strongly rely on a family member or a person who's a proxy to the patient.
Thank you very much, Dr. Mathe. And I'm going to add to the one for more information there is, how do you deal with the patient's special needs in terms of side effects of treatment or quality of life there? Sounds like a very difficult question to ask, and perhaps you can try take a shot at that one, Dr. Venter.
Dom, can I just say that we must never forget as clinicians, what we must look at is do no further harm, right? Okay. So it often amazes me when you've got people who really battling in bad diseases, etc., and they can't make decisions. Our family is desperate for them to make decisions that might not be in the best interest for the patient. And I think as clinicians, we must always remember that. We need to be honest, and we need to make sure that we're not treating for the sake of treating, because that's how we've been taught.
Thank you very much, Prof.
So maybe to ask a question to Prof then, if in a case where someone is not at full capacity, with some cognitive disability, and the role of informed consent when you're giving, when you're considering surgery or chemotherapy or radiotherapy, becomes tricky.
You're right, it's very tricky. So, for example, I've recently had someone with quite significant cerebral palsy and a breast cancer. In fact, I've got a lady I'm seeing tomorrow, and she's got a lazy luminal A cancer. I don't think it's fair for her to have surgery when I can put on an endocrine treatment and look at freezing the cancer, and that's easier to explain to her than being in a hospital. So we need to make decisions where we are, and if you can't understand what the patient can understand, that we mustn't frighten and harm them. I think that's important. So it's a patient with dementias who are young, okay, and have triple negative cancers, and you have to speak to the family and get consent with them. When should you give chemo, and how is the patient managing and tolerating with that? I think they're not easy decisions. Consent is a big thing for me, okay? Consent is not just about people who can't understand. It's about when you can't speak to someone in their language. Is that proper consent? And it is, you have to have, I've got Charles in the background, more than one clinician, understanding, and then really it's about teamwork. Have you gone to the nth degree to make sure that you are doing no further harm?
That's a very good point you do bring up there. So, Dr. Mathe and Dr. Fent, I'm going to ask this question to you now. We have had a lot of very difficult and pertinent points brought up to here, and I'm sure there are a lot of people who are listening into this who have now had this topic awakened and brought up in their mind. I'm going to ask if there's someone watching tonight who wanted to start preparing for this tomorrow. Is there some advice you could give to them? Let's say they've been listening to this, they're on their way home. How do they start approaching this conversation with their family and their associates? And perhaps because you've dealt with this a lot professionally, you might have a different point of view of experience of how is the best way to start broaching this topic? What advice can we give to our listeners? And whether this is from a medical point of view from you, Dr. Fenter, or supportive from Dr. Matebe, or even approaching the legal discussion with your partners, how do I start? I want to go and make a will. Perhaps if anyone wants to kick that conversation off, let's see if we can give some advice to our audience here.
For me, I will say to the audience, these conversations should begin as early as possible, and they should ideally become part of the routine in healthcare discussions. While some patients may raise the topics themselves, healthcare professionals, I always say, have a responsibility to create opportunities for this conversation rather than waiting, when we are in a healthcare context, rather than waiting for the patients to raise these conversations. We need to, raise them with the patients, but, we need to be sensitive about raising these conversations. We just need to be, provide a safe space when we raising these conversations with the patients. Yeah, I would say my advice is to start these conversations early and revisit them regularly, and recognize that preferences may evolve over time as circumstances change.
Dominique, I've put in the chat a link to the conversation project. So there are various. So I think that first of all, to be clear that there's this difference between a will about, and around your assets. And for that, you need to go and see your lawyer. And I don't know whether there are alternative ways of doing that, Evie and John, you'll be able to say. But around the advanced care plan, the healthcare plan, there is this link, and there are others, but the Conversation Project, I think, is quite a nice one to follow, because it gives you a guide onto how to have this conversation with your family, and it gives you a document that you can complete. So it guides you through the type of questions and things you should be thinking about. And I think perfectly fine if you were to complete and sign that to use even within the South African context, because it's not a legal document per se. But it helps you, it gives you a little bit more information about how to think about identifying a surrogate decision maker. It's a really good resource to use, just to float your ideas and get them kind of organized. And then I would encourage you to, as I said, to engage then with your GP or your palliative care team or the social worker in your oncology clinic, and say, look, you've thought about this, you ask for help, and those would be the people to ask for help. But it's important to do. But
Yeah. Thank you. And I think what's also important is also to remember that the importance of having a will comes from very early and young age. It's not just, something to consider when you reach a certain age, or if you are healthy or unhealthy. It's so important that everybody has a will. And wills will normally change between periods of 2 to 5 years, depending on your own life, your circumstances, where you are when you first did your will versus where you are 5 or 10 years later. So it's not to say that you have one will drafted and that will be your will going into however many years later. So very important also to know, to let listeners know that a will is not only made if you have money and assets. It goes beyond that. It's not just for wealthy individuals. All of us, or most of us, have some form of assets, whether it's a vehicle, a bank account, personal benefits, a life policy, personal belongings, even digital assets. A lot of the times people are now investing in Bitcoin, and they don't often get included in the will. But more importantly, a will address issues beyond money, such as guardianship of your children, and who should administer your estate. So regardless of the size of your estate, the will provides certainty and guidance for those that are left behind. And as we said, it's so important to always review it depending on your circumstances and where you are. The biggest mistake I think people make is that you don't update it, and you think family will just work it out. And that's where it becomes the most challenging part, because a lot of the times the family members that are the ones that have to administer the estate post that are not certain of certain items and documents, and can delay the estate and finalization thereof.
Yeah, and I think just to add quickly to what Evie said, anybody can draft a will. As long as you're 16 years of age or older, you can draft your own will, as long as it complies with certain requirements in terms of the Administration of Deceased Estates Act. But it's a discussion that we have with all our clients. We always do what we call a legal risk audit, and one of the questions is, do you have a will? Do you have assets? What happens to you if you pass away? What will happen to your kids, etc., etc. So any of you can approach any firm of attorneys or download information, and it's not a difficult thing to do, as I said, as long as the guidelines are as per the Administration of Deceased Estates Act.
Thank you so much, John and Evie. And I'm going to ask you to continue on with one or two more questions before we move back to Dr. Matebe and Fenta. You mentioned there for parents of minor children and the planning around that. That's probably a very relevant point for a lot of patients and a lot of people who go there. Is there any additional planning that needs to be made around guardianship? And what actually happens if those arrangements has not been made? I don't know if that might be the wrong question to ask here.
No, it's a good question, and your will should indicate what happens to minor children in the event that both you or your spouse passes away simultaneously. Generally, a guardian is normally nominated in the will, and that should be somebody that the family trusts, somebody that the kids know, and often somebody that has children themselves. But generally, the will specify what happens to minor children in the event that something happens. Also, very important that we describe how the estate ought to devolve on minor children. Often testators and people who are interested in drafting those types of wills include a trust in the will, which will ensure that the assets devolve to the beneficiaries who at that stage are minor children over time, so that the estate is not plundered, for want of a better word. But generally speaking, a good will always take care of the minor children.
Thank you so much for that. I'm then going to bring up a question that we received in chat and expand on it. Someone's married in community of property. Can they nominate someone else to take care of their assets and finances through the will? Probably a bit of a very specific case. I'm also going to include a more general question about what happens or what protections can people consider if they have a life partner but they're not legally married? Two different sides of a coin there. Go for it.
Two different questions. We'll answer the married in community of property first. You don't have to nominate your spouse, whether you're married in community of property or antenuptial, as the executor of your estate. It's recommended, but it's not necessarily always done in practice. So you can nominate anybody that you trust, that you believe will act in the best interest of the estate, to be an executor. And then, of course, what also happens is when you nominate an executor, that executor also has what we call the power of assumption, which allows the executor to appoint other professional people, whether it's an attorney or a legal question that arises, or whether there's going to be some accounting issues that are going to arise. Either an accountant or an attorney can be assumed as an executor, or a third person can be nominated as an executor to assist in the administration of the estate. With regards to your second question, would you mind just repeating it again for me, please?
The question is, what protection should people consider if they have a life partner but they're not legally married?
Yeah, so that's a very good question, and it's often come up where we have cohabitation agreements that are normally drafted and are recommended. So a life partner does not automatically inherit in terms of a will. So we would definitively advise those individuals that are in these so-called common law marriage, that used to be the old terminology, it's now cohabitation. We would recommend that they enter into formal documentation in order to ensure that that life partner is able to inherit in terms of an estate.
Thank you so much. And the last legal question I'm going to throw your way tonight is, besides a will, what other important documents should adults consider having in place?
Go for it, Dave. So we believe that there should be some type of legacy pack. We call it a legacy pack. And basically what it is, it's an organized estate planning and personal information system. And what we like to include in that pack is a last will and testament, a letter of wishes, which is, for example, how I would like my funeral to be held, a description of what the estate process should look like, an asset and liability schedule, because it's very important that the numbers match up and everybody knows where all the assets are. We also like to include a glossary of all terminology, because often what happens is people are not educated enough, unfortunately, and the more information, as I said earlier, they have, the easier it is for them to understand the process of the lodging of the estate. Funeral wishes, very important. Key contacts, professional advisors numbers, the attorney, your accountant, your insurance broker, all of that stuff should be on hand. And then what life after you should look like. It's very important sometimes that you tell your family how you would like their lives to continue. So we try to put as much information as possible. And Dom, just one thing before we leave the legal, what we found in practice is that it's very important that all of this information is kept in a protected environment. Very important to discuss all of these things with family members, particularly those that are going to be the executors of your estate, in order to ensure that they know where to find everything, particularly your last will and testament. So often what happens is that we try to lodge estates with the Master of the High Court, and we try to get letters of executorship, which is a document that authorizes a nominated executor to handle the affairs of the estate on behalf of the beneficiaries, and the master asks for an original will. And you can't believe how many times clients are unable to locate that original will. And that can cause tremendous problems, because not only do we have delays sometimes at the Master of the High Court because we don't have a will, we often have delays at the Master of the High Court just because that's the way things are. Often things are backed up, and it can take sometimes up to 6 months to get a letter of executorship, which is an important document, because without that, the estate cannot be devolved at all. So we advocate to our clients to have what we call a red book or a black book or a file or something in an important document holder in a safe place that your family is aware of, where they can access this type of information. Hope that's helpful.
Thank you so much. Very comprehensive and definitely helpful. Dr. Fenter, I see you did post another link for us in the chat.
Yes, so that is a link. So I was just going to say some of our stuff is in my husband's what is it, close in his safe, but no one knows how to get into that stupid safe. So even though we know where it is, we just won't be able to get to it. But the link that I've posted is from the Palliative Care Practitioners Association website, and it's a blog that was written by Rebecca Lazarus, who's a social worker, and she's compiled there a list of all the things that you need to think about, when planning the bigger picture around financial and legal matters, but also your digital legacy, passwords. So she's got a whole list of all the things that you need to think about, accounts, and I think it's a handy tick sheet to use in planning. So that's the link that I've put there.
Thank you. Probably definitely something useful if you can go through a checklist as you mark it off. I'm going to go back to a comment that I heard from Prof. Benn earlier, and I'm going to direct the question to Dr. Mathe. Prof. Benn mentioned about how the importance of speaking to someone and if they understand you, and whether language barriers happened or cultural barriers happened. Dr. Mathe, my question to you is, since South Africa is incredibly diverse, how do the different cultures and belief systems and even your family structures influence the situations and conversations around illness, death, and planning ahead that you've experienced?
Yeah, like you are saying, South Africa's cultural, spiritual, and social diversity, it has a significant influence on how people understand illness, dying, and future planning. In many communities, decisions are not made by individuals alone, but they involve, extended members. You will speak to the patient and the patient will say, no, let us wait. Let me call my uncle. My uncle is in Polokwane. My uncle needs to come and be part of this discussion. Others will tell you that, we have community leaders who need to be part of this. Others, they will say, I have my spiritual leader or my sangoma. We cannot make any decision without involving my spiritual leader. So, beliefs about illness, suffering, death, and the afterlife may shape how families approach discussions about care and future planning. Some families view open conversations about death and dying as inviting misfortune. Like, don't talk to us, like don't even go there, because immediately once you start that conversation with us, it means you are inviting death into our family. You are inviting bad things. Others, they will say, you lack faith. There's no way you'll talk to me about that subject. It means you don't believe. So others will see such discussions as a responsible way of protecting their loved ones from uncertainty. So as healthcare professionals, it is very much essential that we approach each and every family with cultural humility. We need to be aware of people's cultures out there. With curiosity, you need to be curious about other people's way of life. And respect, I will emphasize that, rather than making assumptions about their beliefs or preferences. So no assumptions, healthcare professionals, respect. And just be curious, approach them with humility. I always say effective advanced care planning acknowledges individuals' wishes while also recognizing the importance of family, culture, spirituality, and community. People out there are part of communities. Whatever they do, the community needs to be involved. And also we need, by creating a safe space for dialogue, we need to create, as healthcare professionals, we are judged most of the time because people feel that we don't care, we are heartless, you know what, we don't approach them with dignity and respect that they deserve. So we need to be careful, and whenever we are approaching, some discussions, let us create a safe space. We are doing this so that families can navigate these conversations in a manner that aligns with their values and traditions.
Thank you so much, Dr. Mathe. That is a very comprehensive aspect there. Prof. Benn, if you want to put a quick comment as well.
I just want to say how important it is for clinicians because, for many people in this country, when you're dealing with death, there are so many costs. And around clinicians, I often have the conversation is please get the palliative supportive team involved, because having someone die in a hospital when it is better for them to go home to their village and the place where they come from requires traveling, bringing the spirit back, and maybe more costs of bringing the right branch to transfer. There's so many nuances around it, and we need to be aware of that as clinicians. So it's not just about admitting someone into the ER who is an end-stage cancer and having them in a bed, and everyone wondered around why the patient has to die in a hospital. So that's why this concept, and I really push for supportive care understanding and not palliative understanding, means you bring it up and you get whoever needs to be involved sooner than later. It's really, really important. So thank you for what you've said.
Thank you very much, Prof.
Even consider that we understand, in my way, can be showing a lack of respect. Okay. So, I mean, I'm dealing with a family at the moment where someone's died in one of the government hospitals and they had some private, and they're asking me they can't get money from policies and everything. And I'm trying to work out navigation and who can get access to that, because that family needs that money. It's a big thing for me from a government point of view when people wouldn't sign on death certificates and help out around issues that are really critical and create huge cost burden to families when they don't need it at that time.
Thank you, Prof. Benn. Definitely something that needs to be considered by medical professionals. I'm going to start bringing it all together, and I'm going to ask Dr. Venter if you want to lead this discussion. I'm going to say we have covered a lot of different topics this evening. What do you think being prepared actually means from your perspective? You have probably dealt with numerous patients who are in requirement of palliative care, these documents potentially legally, this extra support. If we were to find this balance between planning responsibly for the future and being prepared from your perspective.
Sure. I think I think it's to realize that these conversations are often about the what ifs. Things are uncertain, and this conversation is simply about the what ifs. So I was privileged enough to be in the Timavati not so long ago, and we were on a drive, and apparently there's a baby white cub somewhere in the veld. And these guides were looking for this cub in particular, but and then it got dark and we were driving in the dark, and then the guide said, if we see, she's just warning us, if we see the white cub now, we can't actually stop and view it because it's younger. So then the two guides had a whole conversation about, can we view it or can't we view it? And I said, well, what are the chances of us ever seeing this cub anyway? They said, she said she knows, but the point is, if we don't have the conversation now, when we see the white cub, we're not going to know what to do. And I thought this is actually a little bit like advanced care planning, because you don't know. So have the conversation now, and don't feel that this is going to be bringing it on, as you say, Penelope. So I think to also just have a pause and think for yourself what matters most and how do I want to spend my time? Because I think one gets so sucked into the medical and the scans and the bloods, there's very little time and headspace to just pause. So I think maybe I would want to encourage people to pause and to reflect on these things a little bit. Maybe write some of it down just to get clarity in your own head and then decide, where do I go with this next? Do I speak to my partner? Do I speak to my doctor? Do I have a good relationship with the social worker? Just to get started.
Thank you so much, Dr. Fenter. And I've probably made you already answer my final question for the night. So I'm going to put you to the end of answering this one, giving you a moment to think about it. But I like to finish every single webinar by offering each of our speakers an opportunity to say if there was a single thought you wanted to take away from tonight's webinar, from your perspective, what would it be? And I'm going to expand on that question for this one only and say, give me a single thought, as well as if there's one thing you'd want them to do after this webinar as well. What would that one action be? So I'm going to go for our silent observer this evening. Prof. Benn, if you want to give your answer to that question, and then we'll lead through all our other speakers.
So I think as a clinician, you must listen to your patient and your family. You need to be honest always. And for me, it's always about teamwork. So why as clinicians, we're not asking for help, around probably aspects of care that we absolutely no question don't manage properly right from the beginning. That's what we need to do. So the one thing I would encourage is that part of multidisciplinary care is having supportive care teams on board, okay, and getting them involved in people care, not just patient care, sooner rather than later.
Thank you so much, Prof. Benn. John and Evie, perhaps you'd like to go next for me, a thought from you and a desire of what you'd like to see people do.
Thank you. For me, I think the thought for today would just be make a start. Whether it means drafting your first will, reviewing an outdated one, speaking with your loved ones about your wishes, or simply just making an appointment with a professional advisor is taking the first step. You don't have to have all the answers today. What matters is the beginning of the conversation and putting a plan in place that can evolve over time. And as we often say, hope for the best, but give your loved ones the gift of being prepared for the rest. That is really such a big blessing at the end. And I would take that as the take-home message, just a start.
Thanks, Evie. I think I would sum it up and say that the will is so important because it gives you a voice when you're no longer able to speak for yourself.
Thank you so much for that. Dr. Mathe?
For me, take home is start the conversations early. And those conversations need to be honest. You need to have these honest conversations. And also you need to understand your options and ensure that your wishes are known to the people, your family, carers, etc.
So much. And last but not least, we're back to you, Dr. Fenter.
Oh man, I hate rounds like this. It puts me on the spot. I maybe just with the quote by Ellen Goodman, who was the author of this conversation project, the link that I sent in the post. She said, "It's always too soon until it's too late." And I think that ties in with what everyone has said. Is really just get cracking with
Thank you
compassion,
so much.
but that it is a gift. Yeah.
Thank you so much, and thank you to all our speakers tonight. And a special thank you once again to the Breast Health Foundation for bringing together conversations like this and their ongoing commitment to supporting the cancer community through education, advocacy, and patient-centered initiatives. If we have a representative from the BHF who wishes to give us a final word from their point of view, I welcome you to come join us.
Lou, you can pop on if you want. Your mic and camera's off.
I will allow Louise. Just give me one moment. I'm going to add her onto the speakers and she can give us a.
I see her hand is up.
Oh, there we go. Lou, you should be able to unmute yourself. You should be able to turn your, put your camera on now. Let me add you to the spotlight.
Oh, thanks, Dom, for giving me a voice. So I'd like a huge thank you to all our speakers this evening. This has been a topic that I've wanted to do a webinar on for months. And I think we as navigators and people working in the cancer community are always scared to bring up this topic because it's not something our cancer patients always want to speak about. So thank you very much. Hopefully this is the beginning of future conversations like this, because even for us with our patients, this is hard. It's really hard. And I think having experts and your opinions on this and dealing with people in situations, not just in the cancer journey, but in life, everyday life. We don't even speak about this during our everyday life, and during illness or sickness, it's even more difficult. So thank you, everyone. I really appreciate you all coming on board. I've learned a lot. I'm going to have a look at that advanced directive, Dr. Venter, and reassess it, as I believe it's not valid in South Africa currently. But thank you, everyone. I appreciate all your input. And yes, let's keep planning for the rest.
Thank you so much. And as Louise said, thank you to everyone who joined us. It's our audience that drives these initiatives. Your participation and your interest in these discussions is why we do it. If tonight's discussion encourages even one important family conversation, then we have achieved exactly what we set out to do. Please be aware that the recording of tonight's event will come up on the Breast Health Foundation social media page, their YouTube channel. So if there is anyone who you feel would benefit from listening in on this discussion, please feel free to share with us. Hope and preparation are not opposites. We can do both. Good night, everybody, and thank you for joining us.
Thank you very much. Good evening.
Thank you, everybody.
Thanks, Dom.
Bye.
Bye.